Acute kidney injury (AKI). 1. Definition KDIGO. Acute kidney injury (AKI). 1. Definition KDIGO. AKI is defined by any one of the following: serum creatinine 0.3 mg/dl within 48 hours, serum creatinine 1.5x baseline within prior 7 days, urine output 0.5 ml/kgh for 6 hours. 2. Staging of AKI, KDIGO, rifle criteria for AKI, based on creatinine GFR or urine output, changes over 7 days, are, risk creatinine, x 1.5, GFR, 25% urine output, 0.5 ml/kghr for 6 HRSI injury creatinine, x2, GFR, 50% urine output, 0.5 ml/kghr for 12 HRSF failure creatinine, x3, GFR, 75% urine output, 0.3 ml/kghr for 24 HRS or anuria for 12 HRSL loss of function, complete loss of renal function for 4 weeks ESRD, and stage renal disease, ESRD for 3 months. 3. Causes of AKI: prerenal, renal, postrenal, prerenal, perfusion, hypovolemia, bleeding, vomiting, diarrhea, hypotension, shock, anesthesia, NSAIDs, afferent flow, ASA-ARBs, efferent tone, sepsis, cirrhosis, hepatorenal syndrome. 3rd spacing pancreatitis, nephrotic syndrome, B intrinsic renal parenchymal damage, I acute tubular necrosis, ATN, ischemia, prolonged prerenal state, nephrotoxins, contrast, aminoglycosides, cisplatin, rhabdomyolysis, myoglobin. 2. Acute interstitial nephritis, AIN, drugs, NSAIDs, penicillin, PPIs, infections, autoimmune SLE, Sjogren. 3. Glomerulonephritis, GN, post-infectious, good pastures, lupus nephritis, ANCA vasculitis. 4. Vascular, TTP, Hus, malignant HTN, embolism, infarction, C post-renal, obstructive, BPH, prostate cancer, bilateral stones, pelvic mass, retroperitoneal fibrosis, neurogenic bladder, urethral stricture, ultrasound. Hydronephrosis suggests obstruction. 4. Risk factors, perioperative context, age, 65, CKD, diabetes, liver disease, cardiac disease, sepsis, hypertension, major surgery especially liver, vascular, biliary nephrotoxins, NSAIDs, ASA, ARBs, aminoglycosides, contrast, rhabdomyolysis. Hepatorenal syndrome, intra-abdominal hypertension, dehydration, urinary obstruction. 5. Investigations: creatinine, EGFR, for diagnosis and monitoring, urea nonspecific, with GI bleed, diuretics, sepsis, electrolytes especially KABG, assess acidosis. Anion gap ECG, look for hyperkalemia, ultrasound CUB, rule out obstruction, urine indices, caution, diuretics may alter these values, urine indices, prerenal, Na, 20, Osm, 500 ATN, Na, 20, Osm, 500, less reliable if on diuretics. 6. AKI versus CKD, how to differentiate, special tests, PTH, phosphate, calcium, disturbed in CRF, urea creatinine ratio, 20, 1 suggests prerenal AKI, fractional excretion of sodium phena, limited use of CKD is advanced. 7. Management principles: A. General goals: maintain MAP, 80 mmHg, ensure urine output, 0.5 ml/kgh, check catheter patency, avoid nephrotoxins. B. Intraoperative IQ, monitor for intra-abdominal hypertension, IAP, 20 mmHg, anuria. Use inotropes if needed to maintain renal perfusion. 8. Medication-related measures: stop nephrotoxic drugs, NSAIDs, ASA-ARBs, K-sparing diuretics, aminoglycosides unless essential, avoid metformin, risk of lactic acidosis, contrast-induced nephropathy prophylaxis, NACO3 1.26%. 3 ml/kgh x 1 hour pre-op, 1 ml/kgh x 6 HRS post-op, N-acetylcysteine PO optional, diuretics not routinely used, in oliguric AKI, IV furosemide 20-40 mg, only if fluid overloaded, oral furosemide 250 mg, in dialysis. Dependent patients, no benefit from low Dose dopamine mannitol 0.5 gkg IV may promote diuresis selectively. D1 to call IQ renal team hyperkalemia severe acidosis symptomatic uremia pulmonary edema fluid overload dialysis requirement 10. Final clinical framing. This is likely AKI. I will first ensure hemodynamic optimization and assess for reversible causes. If the diagnosis is uncertain, AKI vs CRF, I will treat supportively while trending labs and imaging. Renal biopsy may be considered if the etiology remains unclear. Step 1. Clarify the clinical context. Start confidently. This patient is dialysis dependent. My first step is to differentiate between acute renal failure ARF and chronic renal failure CRF. As management, prognosis, and anesthetic implications differ significantly, ask or assume based on scenario. Is this a known ESRD patient on maintenance dialysis? Or is this a new presentation requiring dialysis? Possible ARF. Step 2. History clues to ARF vs CRF. Ask the following focused questions. Onset and duration of symptoms. ARF typically presents acutely over days to weeks. CRF is slow and progressive over months or years. Urine output changes. Sudden drop in urine output suggests ARF. Gradual reduction or stable low output suggests CRF. Precipitating factors. ARF often has a trigger, sepsis, dehydration, drugs, or contrast. CRF usually does not. Past renal history. Ask if there are any previous creatinine records or known CKD history. Symptoms of uremia. CRF patients may have anorexia, fatigue, pruritus, weight loss for months. ARF symptoms are recent and more dramatic. Step 3. Examination. Spot the physical clues. Skin changes, scratch marks and uremic frost suggest CRF. Pallor and signs of anemia, more common in CRF. Volume status. Assess for signs of fluid overload like pedal edema, pulmonary crackles. Dialysis access. Temporary catheter e.g., femoral or IJ may suggest ARF. Mature AV fistula or graft usually indicates CRF on regular dialysis. Bone deformities, renal osteodystrophy and long-standing CRF. Step 4. Investigations. Differentiating ARF from CRF. Here's how key tests help. Ultrasound. Kidneys, normal-sized or swollen kidneys suggest ARF. Shrunken, echogenic kidneys suggest CRF. Hemoglobin, normal or near normal in ARF. Low in CRF due to chronic erythropoietin deficiency, calcium, phosphate, and PTH. CRF is associated with hypocalcemia, hyperphosphatemia, and secondary hyperparathyroidism. Serum urea creatinine, both elevated in ARF and CRF. Not helpful alone. Urea creatinine ratio, 20, may first point to prerenal ARF. Electrolytes and ABGs, look for hyperkalemia, acidosis, and anion gap. Common in both, but CRF patients may show adaptation. ECG can show hyperkalemia changes in both. CRF patients may tolerate higher potassium levels. Urine studies, fractional excretion of sodium phenol, urine osmolality, and microscopy can help differentiate prerenal ARF from ATN, but less useful in advanced CRF. Step 5. Final word. When in doubt, end smartly. In some cases, it may not be immediately possible to distinguish ARF from CRF without trend data or imaging. In such situations, we manage supportively and reassess renal recovery over time. Renal biopsy may be considered if cause remains unclear. Definitions. AKI, acute kidney injury, abrupt deterioration of kidney function occurring over 48 hours. CKD, chronic kidney disease, deterioration of kidney function with GFR 60 ml min 1.73 m to the power of 2 for 3 months of presence of structural kidney damage. Additional notes. Dialysis dependence typically begins at grade 5 CKD. Normal GFR 90-120 ml min 1.73 m to the power of 2. GFR decreases progressively with worsening CKD stage. CKD definition. Recap. CKD equals deterioration of kidney function persisting 3 months with GFR 60 ml min 1.73 m to the power of 2. Causes of CKD: diabetic nephropathy, hypertensive nephropathy, glomerular disease primary, e.g., IgA nephropathy secondary, e.g., lupus nephritis, tubulointerstitial disease, obstructive uropathy, hereditary disorders, e.g., adult polycystic kidney disease, ADPKD, treatment of CKD-1. Treat underlying cause, manage diabetes, HbA1c, 7%, control hypertension, target BP 140/80 mmHg, 2. Slow progression ACE inhibitors, ARBs, tight glycemic and BP control, 3. Manage complications, anemia, iron, erythropoietin, EPO, acidosis, if pH 6.9, sodium bicarbonate, fluid overload, salt restriction, diuretics, bone disease, phosphate binders, vitamin D4. Lifestyle modification, low protein diet, salt restriction, avoid NSAIDs and nephrotoxins, encourage exercise. 5. Prepare for renal replacement therapy, early nephrology referral, AV fistula planning, dialysis or transplant preparation. Note: patient who is dialysis dependent, GARD 5 CKD, manifestations of chronic kidney disease. Neurological system: peripheral neuropathy, distal symmetric, autonomic dysfunction, muscle twitching, uremic encephalopathy, lethargy, seizures, coma, asterixis, metabolic changes. Metabolic acidosis, K naught mg to the power of 2 phosphate, vitamin D, Ka to the power of 2, secondary hyperparathyroidism, hypocalcemia, hypoalbuminemia, cardiovascular, CVS, fluid overload, edema. Weight gain, CCF, pulmonary congestion, hypertension, due to fluid retention, ROS activation, pericarditis, uremic chest pain, pericardial rub, vascular calcification, arrhythmias. Conduction blocks, atherosclerosis, CV, risk, elevated troponins, not always ACE, check TEG, gastrointestinal system, GIT, anorexia, nausea, vomiting, delayed gastric emptying, hyperacidity, mucosal ulceration, infection risk. Especially GI pathogens, respiratory system, hyperventilation, compensation for acidosis, interstitial edema, alveolar edema, pleural effusion, hematological anemia, EPO, RBC, survival. Platelet dysfunction, bleeding tendency, leukocyte dysfunction, infection risk, check clotting with TEG, endocrine glucose intolerance, secondary hyperparathyroidism, hypertriglyceridemia. Skeletal renal osteodystrophy, periarticular calcification, osteoporotic fractures, skin hyperpigmentation, ecchymosis, pruritus, management of ESRD for surgery, structured into pre-op, intra-op, post-op. 1. Preoperative assessment, A. History, cause, duration, treatment of ESRD, dialysis details, type, frequency, route, last dialysis session. Urine output, day, electrolyte abnormalities, K must be rechecked, 6 HRS before surgery, anemia status, HB%, fluid status, dry versus overloaded, comorbidities and current treatment, functional capacity, METs, cardiac, HB8-10 GDL, renal. 8 GDL, GERD, weight loss, IQ, post-op planning, B examination, general physical exam, GPE, pallor, anemia, edema, JVPRVE, muscle wasting, malnutrition, systemic exam, respiratory system. Crepitations, breath sounds, dull, percussion, hyperventilation, metacidosis, cardiovascular system, JVP, pericardial rub, pulse volume, bounding pulse, arrhythmias, S3 gallop, LVH, CNS manifestations, peripheral neuropathy. Motor autonomic, uremic encephalopathy, confusion, lethargy, asterixis, C pre-op investigations, blood tests, CBC-HB, WBC, PLTs, anemia, infection, thrombocytopathy, ASK, on erythropoietin, duration, frequency, TEG if available, assess platelet function, Beatty, CT, required before epidural electrolytes, repeat within 6 hours pre-op. K postpone elective surgery for K, 5.5 mcL/na, Ka to the power of 2, mg to the power of 2. PO43 negative, PO4, Ka, mg not ventilated, urea, creatinine, BSR, insulin resistance, ABGs, metabolic acidosis, ECG, arrhythmia, hypertrophy, conduction blocks, echo, if METs. 4. Check diastolic dysfunction, CXR, pulmonary edema. Pleural effusion, cardiomegaly, preoperative optimization, ESRD patients, key principles, fluid management, maintain euvolemia, optimize blood pressure, dialysis timing. Perform dialysis 4 to 6 hours before surgery. Ensures fluid balance. Wash out of heparin. Check urine output. UOP. Labs to be done post-dialysis. CBC-HB, WBC, PLT. Electrolytes. Renal function tests, RFTs. Coagulation profile. Body weight. Weight management. Focus on dry weight. Weight after dialysis. Compare with current weight to assess fluid overload. Signs of overload. CVP. Basal crepitations. Pitting edema. Clinical auscultation. Important checks before surgery, especially dialysis-dependent patients. Parameter, target action history, cause, duration, treatment comorbidities. Assess and optimize last dialysis within 6 hours pre-op. Urine output day. Record baseline electrolytes, especially Kmax6 before op. Hemoglobin. Check for anemia. Fluid status. Compare with dry weight. Bleeding time. Platelets, to assess platelet function. BSR. Due to insulin resistance. Functional capacity, e.g., METs, exercise tolerance. Intraoperative management and ESRD. Aims 1. Hemodynamic stability. 2. Prevent further renal damage. 3. Careful drug and fluid handling. 4. Adjust technique based on systemic and renal involvement. Anesthesia management. Pre-medication. Continue routine medications. Anxiolytic, if needed. Aspiration prophylaxis. Induction RSI if aspiration risk. Check K before RSI. Use slow IV induction to prevent CVS collapse. Preferred agent, etomidate. Propofol maintenance agents, isoflurane, sevoflurane. O2 muscle relaxants, atracurium, cisatracurium. Monitoring. ASA standard monitoring. Invasive BP CVP and urine output monitoring. Preserve AV fistula arm. Avoid needle stick or BP cuff on fistula site. Analgesia. Prefer none. Opioids. Avoid NSAIDs use. Regional with caution. Check coag status. Hypothermia. Avoid. Impairs coagulation, worsens acidosis. 2. Fluid and electrolyte management. Aim, euvolemia. Prefer plasmolyte. Avoid RLNS. Risk of K. Hyperchloremic acidosis. Avoid glucose-containing solutions. Avoid starch-based colloids. Nephrotoxic. Replace blood loss with balanced colloids or PRBCs. 3. Ventilation. Avoid hypoventilation. Worsens acidosis. Avoid excessive hyperventilation. Alkalosis can cerebral perfusion. Shift O2 HB curve left. IV. Special notes. Drugs to avoid muscle relaxants, pancuronium, rocuronium, vecuronium. Opioids, morphine, use titrated, pethidine, tramadol, codeine. Induction, ketamine. SNS inhalational, halothane, enflurane, arrhythmogenic. Drugs and chronic renal failure. CRF premedication, safe. Lorazepam. Induction agents, safe. Propofol. Safe with dose reduction or careful use. Ketamine, etomidate. Contraindicated, none specifically listed, but caution with ketamine. SNS stimulation maintenance. Inhalational agents, safe. Isoflurane, desflurane. Safe with dose reduction. Sevoflurane. Contraindicated. Enflurane, nephrotoxic, arrhythmogenic. Muscle relaxants, safe. Atracurium. Cisatracurium. Safe with caution. May accumulate. Rocuronium, vecuronium. Contraindicated. Pancuronium, renal excretion. Opioids, safe. Remifentanil, alfentanil. Safe with caution. Titration. Fentanyl, morphine. Contraindicated. Pethidine, codeine, tramadol. Accumulate. Neurotoxic metabolites, analgesics, safe. Paracetamol. Contraindicated. NSAIDs. Nephrotoxic, local anesthetics, LA, bupivacaine. Safe with dose reduction. Lidocaine. Safe with 25% dose reduction. VAV fistula care. Avoid BP cuff. IV arterial lines and fistula arm. Don't place subclavian catheter in same side. Stenosis if needed. Prefer IJ or femoral access. 6. Infection and GI considerations. Use broad-spectrum antibiotics. Immunosuppression and ESRD. Delayed gastric emptying and uremia. RSI if needed. 7. Miscellaneous. Reduce insulin doses. Clearance and ESRD. Prefer supraclavicular axillary block for AVF surgery. Use local anesthesia in COPD patients. Always assess functional status, electrolyte status before surgery. Post-operative management and ESRD. General measures. Mnemonic, fast hugs and bed component. Notes. Feeding, initiate early enteral nutrition if feasible. Analgesia, use multimodal approach. Avoid NSAIDs. Sedation, judicious use. especially in ICU thromboprophylaxis, mechanical plus or minus pharmacologic, adjusted to renal function, hydration, avoid overload, maintain euvolemia ulcer prophylaxis, stress ulcer prevention in high-risk patients glycemic control, tight control. Renal insulin resistance, sores, pressure sore prevention strategies and dwelling tubes, regular assessment removal when unnecessary NG tube, continue if delayed gastric emptying bowel care. Prevent ileus constipation enteral nutrition, prefer enteral over parenteral delirium prevention, maintain orientation, control pain, avoid sedation excess. 2. Renal function monitoring mnemonic, acid-base balance. W. Water balance. E. Electrolytes, especially Ca to the power of 2, PO43 negative, Mg to the power of 2. T. Toxin removal. B. Blood pressure control. E. Erythropoiesis. D. Vitamin D. Bone health. 3. Specific ESRD considerations post-op ICU, oxygen support and hemodynamic monitoring nephrology review post-op avoid nephrotoxins, e.g., contrast, NSAIDs multimodal analgesia, avoid long-acting opioids early mobilization. High risk of DVT physiotherapy, encourage active rehab titrated epidural dosing, delayed drug clearance infection prevention, strict asepsis, catheter care, respiratory toilet. Important note on hyperkalemia management. High extracellular K makes resting membrane potential less negative, inactivates Na channels arrhythmia risk. Temporizing measures. Calcium gluconate stabilizes myocardium bicarbonate. Insulin glucose, Greek letter beta-2 agonists, shift K intracellularly definitive. Dialysis 1. Hyperkalemia, diagnosis and management definition. Hyperkalemia equals K, 5.0 mol/L. ECG changes typically occur if K, 6-7 mol/L. Ventricular fibrillation VF risk if K, 10 mol/L. ECG changes. Tall T waves, short QT interval, widened QRS, complex loss of P waves, sine wave pattern. Treatment algorithm, when K, 6.5 or with ECG changes. 1. Calcium gluconate, 10 ml of 10%, 0.5 ml kg over 10 minutes stabilizes myocardium by restoring threshold potential. Immediate effect, transient. 2. Glucose plus insulin, 5-10 units of soluble insulin IV plus 50 ml D50. Monitor blood sugar closely. Insulin shifts K intracellularly. 3. Salbutamol nebulization. 2.5 to 5 mg stimulates Na K80pase intracellular K shift. 4. Sodium bicarbonate. 1-2 mol kg IV over 5 to 10 minutes, effective only in acidosis. 5. Calcium resonium. 0.5 to 1 g/kg orally or rectally, slow onset, 12 hours. 6. Low K diet, supportive maintenance measure. 7. Dialysis, definitive treatment. 2. Gastroparesis aspiration risk assessment ultrasound-based algorithm. Perform gastric ultrasound in both supine and right lateral decubitus positions. Assess gastric antrum interpretation. Empty antrum, low aspiration risk, normal induction, solid content, high risk, RSI indicated fluid. Estimate gastric volume. If gastric volume, 1.5 ml kg, low risk, normal induction, 1.5 ml kg, high risk, RSI. Ultrasound picture appearance, air starry sky, solid gray, fluid black, anechoic. Key decision notes for hyperkalemia. K, 6.5 with ECG changes. Dialysis K, 6.5 without ECG changes. Calcium gluconate, ASA grading in ESRD. ESRD on regular dialysis, ASA 3. ESRD not on dialysis, ASA IV due to constant threat to life.